it is my pleasure to introduce Dr. Andrew Lux. He is a faculty member at the University of Washington in the Department of Pulmonary Critical Care and Sleep Medicine. Additionally, he maintains an active scholarly program in the area of high altitude medicine. As I just asked him earlier, he literally is now on the authors who wrote the book. No further ado, here's Dr. Andrew Lux.
So I can see everyone. You don't always clap before you speak. You haven't heard me say a word. This would be the worst lecture in the entire course, and they've already completed lots. So some familiar faces that I just started to work with at the UW School of Medicine. Some others I'll be meeting for the first time today. So it's nice to see everyone here for another good year of the meeting. The topic I was asked to talk about this morning is high altitude medicine, building on what Emily Johnson talked about earlier this morning in her talk on adaptations to hypoxia. I don't have any disclosures to report regarding any of the things that we're going to talk about in the next 50 to 55 minutes or so. So, when people head off to the mountains, whether they're trekking or they're climbing or they're backcountry skiing, quite often the goal is to get somewhere high up into those mountain ranges. People do a whole variety of trips to get onto locations like this. And the problem is when you travel in the mountains, as you might imagine, sometimes those trips are interrupted by some medical emergency that occurs along the way. And it could be something like a traumatic injury. But when people are traveling to elevations of 8,000 feet and above, a big type of medical emergency that can interrupt the trip is that someone develops one of three forms of what are referred to as acute altitude illness. And if you're going along on these trips on a personal basis, or you're the medical point person on those trips, you have to know how to recognize and manage those problems if they develop. So the whole goal of my talk is to take you through a case-based approach to help you be able to recognize and know the basic management principles for the main forms of acute altitude illness and some of the other things that can happen when people are traveling at high altitude. I'm not going to focus on prevention strategies. I'm focusing solely on management. Thinking about you as a medical practitioner on one of these trips having to deal with an emergency if it develops in someone who's traveling. Before I get into that, I want to make three basic points that you need to understand about high altitude physiologic medicine. And as you think about people that are traveling into environments such as this. The first is that in general, unless someone is highly susceptible to altitude illness or has some underlying chronic medical conditions that can get them into trouble, you do not see acute altitude illness until people get above about 8,000 feet in elevation or higher. The second thing, and this is probably the most important principle to understand about the acute altitude illnesses, is the main reason that people get sick. And it's very simple. They go too high, too fast. So someone, for example, who travels up to 15,000 feet in elevation and sleeps there and took only 2 days to get to that elevation is way more likely to get sick than someone who goes to 15,000 feet and sleeps there but took a week to raise their sleeping elevation up to that point. So when people go too high, too fast, that's what increases the risk for altitude illness. But importantly, it's too high, too fast for them. Because the other thing we need to understand is that the ability to adapt to high altitude and the risk of getting sick varies significantly from person to person. Someone might get sick with a single day ascent to 9,000 feet in elevation, whereas their buddy might be able to go all the way to 14,000 feet in elevation in a single day and won't have problems. So there's lots of variability that you'll see in individuals in terms of the physiologic responses and the susceptibility to the acute altitude illnesses. So with those basic points in mind, let's get started and look at some clinical scenarios. So the first scenario is you are working as the medical point person on a group that's trekking in Nepal, and someone comes up to talk to you about their friend who doesn't look there. So the story is, they're on the 8th day of the trek to Everest Base Camp, and you're now in the village of Lobikin at about 16,000 feet. And one of the clients comes up to you because he's concerned that his friend doesn't quite look right to him. And in particular, he was concerned that when he was watching his friend taking a nap, he noticed something wrong with his breathing pattern. I'm going to show you an example of that in a second. So you wake this individual up, you check his vitals, you can see that his heart rate is 101 beats per minute. He's got an oxygen saturation on the pulse oximeter of 82%. He says that when he was exerting himself on the way into low J, he was really out of breath with any exertion that he was doing. Okay? But if he rested for just a couple of minutes, he would feel better. So I'm going to get out of my PowerPoint for a second. I'm going to show you what he looked like when he was taking a nap. Pay attention to his breathing pattern. Okay. So you've got this person with this abnormal breathing pattern. He's hypoxemic, he's tachycardic, he's really out of breath and he's exerting himself. So, the question that I want you to answer is, what are you going to do at this time? You're going to start him on some acetylzolide, give him some dexamethasone, give him some ibuprofen, give him some nifedipine, or just provide some reassurance to both him and his friend who came up and grabbed you in the first place. So talk to your neighbor for about 30 seconds to a minute and see what you How many people want to start this person on dexamethasone? A couple of those. How many people want to give him some ibuprofen? How about some nifedipine? A couple of those. And then how many people just want to provide some reassurance to both these individuals that things are fine? One person. Not half. How's it going? All right. So it turns out the correct answer in this case is you just need to provide both these individuals some reassurance, because what this person is experiencing is a lot of the things that happen to people when they travel at high altitude, even if they're not getting into trouble with acute altitude illness. So one of the things to be aware of is that when you ascend to high altitude, the barometric pressure goes down, partial pressure of oxygen in your lungs goes down, the partial pressure of oxygen in your bloodstream goes down. And the low arterial PO2, what we refer to as hypoxemia, is going to trigger a whole series of physiologic responses. And these are things that Emily Johnston went over in the first hour this morning. And as a result of those physiologic responses, the increases in your breathing, the vasoconstriction in the pulmonary circulation, the increase in sympathetic nervous system activity, as a result of those things, people feel different. They recognize, my heart rate when I'm at rest or I'm doing any level of exertion is higher than it was when I was back home at sea level. They recognize that they're breathing more than normal. This is very noticeable to people when they lay in bed at night and they're having trouble drifting off to sleep. Many people actually have a lot of trouble sleeping at high altitude. They have difficulty falling asleep, difficulty staying asleep, very vivid dreams. And a very common problem that happens to people when they're sleeping at high altitude, even if they're doing fine, is they develop what's known as central sleep apnea, or Cheyne-Stokes respiration. A form of abnormal breathing that was exactly what was shown in that video. You notice that he took a whole series of breaths, and then he had this long pause when he wasn't making any efforts to breathe, and then he started breathing again. That's classic central sleep apnea, highly common in people who travel at high altitude. Many people urinate more frequently when they first get up in altitude, and it's very noticeable that people are way out of breath when they exert themselves at high elevation, particularly in the first couple of days. So they'll huff and puff like crazy, and they may have trained a lot for their big mountain climb, and they're like, oh my God, it's like I've never trained at all, I'm so out of breath. But the key thing is, when they stop exerting themselves and they rest, within just a minute or two, their breathing comes back to normal and they feel fine. So as a result of all those physiologic responses to hypoxemia, people will feel different. And it's important that anyone who's traveling at high altitude understands the way they're going to feel different so that they don't mistake the normal responses to hypoxemia for altitude illness and start treating and acting inappropriately, sending people down to low elevation. So this is a critical thing about treating people at high altitude. You've got to recognize what's normal and be able to distinguish it from when abnormal things are going on. Now, a couple of words about central sleep apnea. It's worth knowing a little bit about this entity. It's highly common, okay, even in people who are otherwise doing great at high altitude, and they're healthy in their normal lives. And as people ascend to higher and higher elevations, central sleep apnea can persist through the course of a very long expedition at high altitude. And it may actually be more common in people who have very strong ventilatory responses to hypoxia. In other words, their arterial oxygen levels go down and their breathing increases. The people who have the biggest increase in their breathing in response to a given level of hypoxemia may be more predisposed to this for reasons that are not worth getting into right now. But in our course later on this year, we're going to go over the mechanisms for this. In terms of how you treat sleep problems that people may have at high altitude, if you use acetazolamide or Diamox, which is the main medication used to prevent acute mountain sickness, it also actually decreases the amount of central sleep apnea and can help improve overall sleep quality. And then people have done studies looking at other sleep medications that are commonly used at sea level, like Zolpidem, which is Ambien, or Zoleplan, or Temazepam, which is otherwise known as Restoril. These common sleep aids at sea level can also improve overall sleep quality at high altitude, but they don't have any effect on whether or not the central sleep apnea is going to occur. For the most part, I don't recommend using medications for the purposes of improving sleep at high altitude unless there's some pressing reason why a person needs to get that good night's sleep. You know, they may have had 5 nights of bad sleep and they need to do something that next day where they have to function well. That may be a situation to do it. But otherwise, if it's not really interfering with someone's expedition or work at high altitude, I generally tend to keep them off medications. All right, our next case. This is the eager athlete. So the story here is you have a group of highly fit triathletes that are going to go trekking to Everest Base Camp in Nepal. And as most people do, they flew into the village of Lukla at about 9,000 feet at the start of their trek. And over a period of only 2 days, got all the way up to the village of Farache with just over 14,000 feet elevation. And in the morning of the third day, one of them comes into the Himalayan Rescue Association's clinic in Farache complaining of headache, really tired, appetite doesn't feel that great at all, and he had slept very poorly the night before. So you examine him and you find he's got an oxygen saturation of 85% while he's breathing air. Color doesn't look great, he looks really tired. Listen to his lungs, they're cleared auscultation, and then you ask him to do some heel-toe walking along a straight line. And he looks just like I'm doing now. So the question is, what are you going to do for him? Are you going to have him descend down to the village of Debauchet, which is about 2,000 feet lower in elevation? Are you going to start him on some supplemental oxygen? Are you going to give him some acetazolamide or Diamox? Are you going to give him some dexamethasone? Or some ibuprofen? Or are you going to give him nifedipine? So chat it over and see what you think the best intervention is. But some acetazolamide, dexamethasone, ibuprofen, nifedipine. So kind of a smattering of answers across the board. I think the best answer in this case is give him some ibuprofen. Just tell him to stay put where he is. You can make an argument for some acetazolamide or dexamethasone. I'll take you through that thought process in a little bit. But what this person just needs is some symptomatic treatment for his headache and to stay put in elevation. Because his problem is going to get better in all likelihood with those interventions. So this person has what's referred to as acute mountain sickness, or AMS for short. By far, the most common thing that happens to people who get up to elevations of 8,000 feet and above. Usually it comes on anywhere from about 4 to 8, 6 to 10 hours after someone's gotten up to these elevations. Although, as I mentioned before, there's a lot of variability between individuals. Some people might develop acute mountain sickness when they get up to 8,500 feet in elevation. Other people are fine at that elevation. It's only when they get up to 12 or 13,000 feet that they might develop symptoms of this problem. Now, in order to say that someone has acute mountain sickness, what you're looking for is a headache plus 1 or 2 other symptoms. And those other symptoms can be the fact that they're really tired, they're kind of persistently lightheaded or dizzy when they're standing up. Short-lived dizziness is very common when people like bend down and pick up their pack or something. But if it's persistent, that's when it's more of a concern. Sick to their stomach, maybe even vomiting. Okay? A headache plus 1 or 2 of those other things in someone who's just come up in elevation is acute mountain sickness until proven otherwise. Now, if you read a lot of older stuff, it'll tell you that poor sleep was one of the diagnostic criteria for acute mountain sickness. In other words, it can be one of those other symptoms. But that has since been reevaluated, and difficulty sleeping has been taken out of the diagnostic criteria for acute mountain sickness. So a headache plus 1 or 2 of those other problems, that is AMS until proven otherwise. In terms of how you treat these people, the most important thing is stop ascending. Don't go any higher in elevation while someone has active symptoms of altitude loss. Second, get them to rehydrate themselves. It's not because dehydration causes acute mountain sickness. That's a fallacy. It's because the symptoms of dehydration are very similar to the symptoms of acute mountain sickness. So you're trying to take dehydration out of the equation in someone who might have been doing a lot of physical activity. And then you're going to use some symptomatic treatment like non-steroidal anti-inflammatories, acetaminophen, maybe something for their nausea. And the majority of people, if you stay put in elevation and do those things, will do just fine. Now, if they don't get better with those interventions, you can consider adding on acetazolamide or dexamethasone. Dexamethasone is going to work faster and it's probably a more effective treatment than acetazolamide, but either one of these things will be fine. But in general, you're going to reserve this for people who are not getting better with the step 1 intervention. In the end, descent or supplemental oxygen will make the symptoms of acute mountain sickness go away. It's just that it's not necessary for the overwhelming majority of people. The only people with AMS who need to descend are the people who don't get better with those conservative measures or get worse at any point. Now, a question that's going to come up is someone's going to develop acute mountain sickness on their trip with you, and they're going to say, all right, can I continue? So I got my acute mountain sickness in Farache. Can I continue the trek with the rest of the group and head on up to Everest Base Camp? So what do you think? Just shout out some thoughts, yes or no? Good or bad? How many people would let someone continue on with their trek? And how many people would say, sorry, it's time to head down? Good. So I think you all have the right approach. People with acute mountain sickness, if their symptoms resolve, they can continue on to higher elevation. You might then put them on some prophylactic medication for the rest of the trip, although not always necessary. High altitude pulmonary edema and high altitude cerebral edema, which we're going to talk about in just a little bit, that's a totally different story. There's actually a lot of debate about whether people who have had HAPE or HACE that resolves with appropriate intervention can then go back up to high elevation and continue their trek or their mountain climb. Highly debatable thing, we're not going to get into that today. But a general principle, though, is if someone who has had altitude illness that resolved wants to continue higher on that particular trip, they have to be symptom-free before they continue their ascent. No one should ever ascend to higher elevations in the face of ongoing symptoms of acute altitude illness. Right. Our next case, the clumsy climber. So the story is you're working on Denali as part of one of the volunteer ranger patrols. And each ranger patrol actually gets to make their own summit attempt on a mountain. So while your group is walking across a part of the mountain that's referred to as the football field, this incredibly long, flat section, just below 19,000 feet in elevation, you see this climber from another party coming towards you that seems to be having difficulty walking. Their group is on the 10th hour of their ascent towards the summit. And they started their ascent from the 17,000 foot camp only 10 hours after they had gone from the 14,000 foot camp up to 17. In other words, they went to 14, 17, waited 10 hours, and then started going up higher. Now, I'm going to show you a video of a different climber, but this demonstrates exactly what this person looked like while they're on the football field. And I want you to pay attention to the way this person is walking. Doesn't look too bad at first. Notice he's actually being short-rolled by his guides because they're very concerned about the way that he is staggering around as he's walking on the mountain. So, that image cemented in your mind here, what he looked like as he was walking. We've got this climber on Denali who looks just like this individual. So, in addition to trying to facilitate descent to this person, which of the following interventions is warranted at this point? In other words, what's the first thing you're going to want to try to do for this person? You want to give them some acetazolamide. You want to give them some dexamethasone. You want to use furosemide, diuretic, hypertonic saline, or mannitol, another diuretic. So chat it over again and see what you think. So, what does this person have? What is he suffering? Okay, this person has HACE, high altitude cerebral edema. So, show of hands, what's going to be the most appropriate intervention at this time? Should you start on a acetazolamide? How many people want to start dexamethasone? Mannitol? Hypertonic saline? And how many people want to give some diuretics? Furosemide. So a smattering of answers across the board for each of those options. The best answer in this case, this patient needs dexamethasone. It's the treatment of choice for people with high altitude cerebral edema. So HACE is extremely uncommon. You're unlikely to see this when you're traveling in the mountains, but you need to be able to recognize it as it develops because it's potentially fatal if not recognized and treated appropriately. The key features of high altitude cerebral edema are that this is a global encephalopathy. Okay? In other words, it's affecting a large part of the brain. So you don't see focal neurologic deficits like the patient can't move their right arm. What you see is they're confused. Their mental status is not normal. And then the hallmark of high altitude cerebral edema is what people refer to as ataxia, or clumsiness. The type of walking that you saw in that video of the climber, who in that case was actually descending from the summit of Mount Everest. Now, as it gets more severe, that global encephalopathy and altered mental status transitions into the fact that this patient is somnolent and you have difficulty waking them up. And then they can lapse into a full-on coma if you don't catch it early enough. And importantly, focal neurologic deficits, like the fact that the patient can't speak or all of a sudden can't move half their body, that's not HACE. You need to be thinking about other diagnoses in that situation. So along those lines, one of the things that's important to remember about traveling at high altitude and doing medical work is when people get sick, we always think about acute altitude illness. But there is a differential diagnosis for a good number of the things you're going to see when people have problems with at altitude. And altered mental status is one of those situations in which you need to have a differential diagnosis. So what are some of the things that might also cause altered mental status at high altitude? Just call them out. What do you think? Hypothermia is a great one. As the temperature drops far enough, mental status is not normal. What else?
Electrolyte imbalances?
Electrolyte imbalances. Which ones in particular?
Sodium would be the one.
Yep, hyponatremia, people are drinking too much free water and sweating a lot. Hypoglycemia would be another one on there. What else? Say the weather's bad, people are cooking inside their tent. Yeah, carbon monoxide poisoning. Okay. Maybe even consider meningitis or various forms of cerebrovascular accidents, such as intracranial hemorrhages like subarachnoid hemorrhage. So you've got to keep these things in the back of your mind for anyone who's got altered mental status. More often than not, it's going to be high altitude cerebral edema. But if the appropriate treatment doesn't lead to a resolution of the problem, then you have to really start thinking more carefully about these other problems. Now, if you go into the literature, there are actually a lot of case reports and descriptions of people having various focal neurologic deficits that have developed at high altitude. So they have this transient global amnesia, or they just all of a sudden can't see due to problems in the occipital cortex of their brain. Or they might have these isolated cranial nerve deficits. These things are not high altitude cerebral edema. Okay, they're probably related to either an atypical migraine or some focal vasoconstriction that's occurring in the brain and affecting a very localized area of the brain. The way you distinguish these types of neurologic deficits from HACE is, in these cases, that's all they had. Their mental status was fine, they're walking fine. It's when you see the altered mental status, difficulty walking in conjunction with some of these other things, that's the patient who has HACE. Now, in terms of treatment, from a non-pharmacologic standpoint, these people need to go down in elevation, if at all feasible. Right? But sometimes the weather's bad, it's late at night, and descent is not possible. In those cases, you want to try to find a supply of supplemental oxygen, or get them into a portable hyperbaric chamber, which I'll show you in a second. And then from a pharmacologic standpoint, all these individuals should be started on dexamethasone. corticosteroid, which for some reason helps improve the edema. No one understands the mechanism for why this develops, and they don't understand quite why dexamethasone works, but it does, and it should be used. Now, it's worth understanding a little bit about how a portable hyperbaric chamber works when people are sick. This is an example of the device, and what it is you put the ill individual in here. There's a tight sealing zipper here that you close up. There's a little window that you can use to communicate with the person. And then there's a foot pump here. And when the person's in the bag, you pump on that foot pump, and you inflate the bag just like it's a balloon. And as you do that, the barometric pressure is going to go up inside the bag, and that's going to simulate a descent for this individual and increase the supply of oxygen to which they're exposed and raise their arterial PO2 and hopefully put out the fire that's causing their altitude rise. So this is an example of a Ganov bag in action. This is my friend holding his altimeter watch while he's standing outside the bag at 14,330 feet. We put him inside the bag, and we pumped it up to about 1.2 psi. And you can see that now the altimeter watch inside the bag is reading 10,720 feet. So simply by putting him in the bag and inflating it sufficiently, we've effected a descent for this individual of over 3,500 feet. And for someone who's severely ill with ACE or HAPE, this may be the way you get their symptoms to resolve sufficiently enough that when the light of day comes around or the weather improves, they may be able to actually walk down in their own power. Or you kept them safe in the bag until a helicopter was able to get in and get them out. All right, so our next scenario actually involves 3 people. I'm going to give you 3 descriptions of climbers on Denali who are all having breathing problems. Now, what I want you to do as we go through these descriptions is think about whether each of these people has high altitude pulmonary edema or not. Okay? So the first climber is a 44-year-old woman, and she has in the past successfully ascended Mount Rainier, Kilimanjaro, and Orizaba, a volcano in Central America. Now at Rainier, she's on her second night at the 11,000-foot camp, and she wakes up with what she describes as gurgling in her lungs. And the following morning, when she gets out of her tent, she goes and sees her guide and checks her oxygen saturation, and it's 86% while she's breathing in. But when she walks, it's 70%. And she'll also say that as she's walking, she's mildly out of breath. So the group stays in camp that day. The next day, the plan is to go from the 11,000-foot camp up to the 14,000-foot camp. And the first thing you have to do is climb something referred to as Motorcycle Hill. So she starts with the group up Motorcycle Hill, and she cannot keep up with them at all. And she actually has to turn around. And when she gets back to the 11,000-foot camp, while she's at rest, her oxygen saturation is 70%. She's out of breath with any exertion, and she's coughing up blood-tinged sputum. No fevers at all, no chest pain. So I want you to just think about this for a second. We're going to come back to this. Does she or does she not have high-altitude pulmonary edema? The next case is a 49-year-old man. He's doing a very similar ascent as she's doing. What his group has done, they've come up to 11,000 feet, but on the way they had cached some supplies down lower at 9,000 feet. And on this day, his group went back down to 9,000 feet to pick everything up. And then on his way back up to their 11,000-foot camp, he comes up to his guide afterwards, and he feels like his vision was starting to narrow in on him. He said he was feeling really tired. He wasn't having any cough, he wasn't having any chest pain, but he said he was out of breath with his physical activity. The guide doesn't have a pulse oximeter with him at this point, and after a little bit of discussion between the guide and the assistant guide and the client, they just decide to do what they call spin him. They send him down the mountain with another one of their guided groups that happens to be done with their expedition and is heading back down to base camp to fly out. The question is, does he have high altitude pulmonary edema? The third climber is a 54-year-old man, and he's made it up to the 14,000-foot camp. And on the morning of the 6th day at the 14,000-foot camp, he feels like he's really out of breath when he starts walking to the bathroom, which is a walk on flat ground at that camp. Now later on in that day, his group is going to try to climb what's called the head wall on their way to the 17,000-foot camp. And on the 1,000 foot of climbing that it takes to get to the base of the head wall, he can't do it. He is so out of breath that he has to turn around and come back down to the 14,000 foot camp. And when he's seen at 14,000 feet by the ranger patrol team, he's got a pulse oximeter reading of 69%. So as I mentioned at the very beginning of today's talk, that people commonly report difficulty breathing when they are exerting themselves at high altitude. And you've got to be able to sort out which difficulty breathing is normal and which is abnormal and suggestive of a person who may be sick with high altitude pulmonary edema. So we have these three climbers that I just described to you that are having breathing problems. Do they or do they not have high altitude pulmonary edema? So chat it over with your neighbor, and as you do that, I will kind of cycle through the cases again if you need to glance at some of the information. So I want you to stock those answers away in the back of your head. We're going to come back and answer them for each of these climbers in a little bit. So the question is, when people are out of breath at high altitude, are they experiencing the normal breathlessness with exertion, or are they starting to manifest evidence of what's referred to as HAPE, high altitude pulmonary edema? This is a non-cardiogenic form of pulmonary edema, meaning left ventricular function is normal in these individuals. They are developing pulmonary edema for a fundamentally different reason than you'll see it develop in patients with heart failure. These people develop pulmonary edema because they have this excessive hypoxic pulmonary vasoconstriction that occurs following ascent. The blood vessels in the lungs constrict more than they should. Pulmonary artery pressure goes up too much, and under those high pressures, fluid leaks out of the vessels into the air spaces and interstitium of the lungs. Now, typically it's seen at elevations of about 8,500 feet and above, and usually people need to be at those elevations for 2 to 5 days before you will see this. After about 5 days at a given elevation, HAPE is unlikely because by that time the person will have acclimatized to that elevation. So you can see this anywhere from 2 to 5 days after people get up to elevations of 8,000 feet and above. In the early stages, people start developing extreme breathlessness with exertion. But unlike the normal individual who's out of breath with exertion but takes a break and within a minute or two feels pretty good, the person who's developing HAPE will take a break and they're needing a lot more frequent rest breaks than everyone else. But on those breaks, it's taken them a long time to recover and get back to normal. And it may be that while everyone's shouldering their packs and ready to go, they're just like, I still need a little bit of time. They often have a dry cough in the early stages of the disease as well. Now, as things get worse and you progress to more and more severe pulmonary edema, that breathlessness starts to occur with very simple activities like walking on flat ground and may even occur at rest. In the late stages, they can cough up pink, frothy-looking sputum. That's because of the presence of red blood cells in that edema fluid. And they're profoundly cyanotic. Their color looks terrible, their lips and their nail beds are blue, and if you check the pulse oximeter value on them, it's going to be super low. Okay? This is some data that was collected in the Italian Alps, where they've actually done a lot of research on patients with AIDS, showing you how profoundly hypoxemic these people will be at a given elevation compared to people who are doing fine. So whereas healthy people in this elevation have an arterial PO2 of 40 millimeters of mercury, it's only 23 in these people with AIDS at that elevation. An oxygen saturation is about 78% in those who are healthy at that elevation, compared to only 48% in people who had HAPE. So hypoxemia is one of the hallmarks of HAPE, and the reason why I bring this up is this is a critical thing about evaluating people who have respiratory complaints at high altitude. If you're the medical person on a trip traveling at high altitude, it's a good idea to travel with one of those little finger oximeters that you can use. Don't use it to do routine checks on people and see how they're doing. Reserve it for the evaluation of someone who has got respiratory problems. And if you throw the pulse oximeter on someone who's got respiratory complaints, and their pulse oximeter is normal for that elevation, meaning it's very similar to the values you're seeing in all the other people at that elevation, it's probably not HAPE. Right? It's probably something else that's going on. It doesn't mean they're not sick, but it's not pulmonary edema. But if you check a pulse ox value and it's markedly lower than everyone else, you've got to be very concerned that they have pulmonary edema, or maybe pneumonia or something else going on. But that's definitely something you're going to be concerned about. So with that description in mind, now let's go back and think about these three climbers on Denali and whether or not they had high altitude pulmonary edema. So the first climber was the woman who had previously climbed Rainier or Orizaba, Kilimanjaro, starts having some difficulty breathing and then has to turn around. And when she comes back down to camp, markedly out of breath, very hypoxemic, coughing up blood-tinged sputum. Does she or does she not have HAPE? Yeah. This woman has HAPE. This is about as classic a case as you will see of this problem. Second individual. This is the person who was teamed at a back carry down to 9,000 feet, on the way back up to 11,000 feet, very out of breath, feels like everything was closing in on his vision. No pulse oximeter value checked, sent back down to lower elevation. HAPE or no HAPE? I see a lot of people shaking their heads, and I would agree that I think it's unlikely, but in the end, it's really unclear, right? And I think the lack of a pulse oximeter check is a key problem in this case. Had you checked the pulse oximeter and his value is markedly lower than everyone else, he may have very well had an early stage of this problem developing. If his pulse oximeter value was normal, it may have been something else. What I was suspicious about when I heard about this case was when he mentioned this idea of everything closing in on his vision, I have a feeling he was anxious. And he was hyperventilating more than you normally hyperventilate at high altitude. And that anxiety played into the normal sense of breathlessness that people have when they're exerting themselves at high altitude. But in the end, without a good thorough physical exam, assessment of his pulse oximeter value, it's very hard to say what was going on. Oops. Third case, HAPE or no HAPE? What do you think? Well, let me ask you, is that ever possible? So I think what fit with HAPE in his case? He's hypoxemic. He is more hypoxemic than you would expect at that elevation. Okay? What else fit with HAPE in his case?
Couldn't catch his breath no matter what.
What's that?
Couldn't catch his breath no matter what.
Right. So he was very out of breath with exertion, much more so than his climbing mates, and he couldn't keep up with them on the trip up to the base of the head wall. So markedly out of breath with exertion, more hypoxemic than you should be, at the 14,000 foot camp on Denali. What's atypical about his case though?
6 days and he wasn't traveling in elevation.
Exactly. They had spent 6 days at the 14,000 foot camp. Probably somewhere along that way had actually made a trip up to higher elevation to cache some supplies before coming back down. And usually if you've spent 6 days at a given elevation, your body should have acclimatized to that altitude already, and the risk of HAPE as well as the other forms of acute altitude illness should fall off significantly. So the fact that this is starting 6 days in should give you a little bit of pause. Either way, he was hypoxemic, did not improve with appropriate therapy, and the oxygen supply was running out because it was the end of the season at the 14,000 foot camp and the end of the climbing season in general, so he was evacuated. And what interestingly happened with him is he gets off the mountain, goes back to the town of Talkeetna, goes to Anchorage, flies all the way back to New York. And when he gets to New York, he gets off the plane, he has some calf pain. And he goes and sees his primary care provider and says, I got this calf pain after my long flight. Primary care provider sends him for a CT pulmonary angiogram. He actually had a pulmonary embolism. Okay? Now, I don't know whether that pulmonary embolism happened on the mountain or it happened during the long flight back, because immobility is a risk factor for venous thromboembolism. But it's entirely plausible that during the 6 days of lying around in his tent at the 14,000 foot camp, he developed a pulmonary embolism at that point. He just didn't have the other symptoms like chest pain and stuff like that. So, people can be out of breath for a lot of different reasons. And you got to be able to tease out when it's HAPE versus when it's just normal breathlessness or when something else might be going on. Now, in terms of treating high altitude pulmonary edema, when you look in the literature, there are some case series where people have described their treatment approach at the Himalayan Rescue Association clinic in Ferriday, and it includes essentially throwing the kitchen sink at these people of a lot of medications, in addition to putting them on supplemental oxygen. Don't write down that list of medications because there is no evidence that you need to use this many medications in order to treat high altitude pulmonary edema. In fact, you'd be worried about the risk of side effects when you combine two medications like nifedipine and sildenafil, which can lower blood pressure. In terms of the best way to treat high altitude pulmonary edema, the key question is, can I access a healthcare facility? So if I'm out in some remote valley of Nepal or Peru trekking around and there's no health facility in sight, the person with high altitude pulmonary edema needs to go down to a lower elevation. And if descent is not feasible, supplemental oxygen if you have it available, or a portable hypobaric chamber if it is available. And I would start these people on nifedipine. It's a blood pressure medication, but it also is a pulmonary vasodilator. It dilates the vessels in the lungs, lowers the pulmonary artery pressure, and relieves the problem that is driving the edema formation. Now, if you can get someone to a health clinic, so say you're at a ski resort in Colorado and you can bring them into the urgent care or ED in town, they don't need to go down. Put them on supplemental oxygen. If you're able to raise their oxygen saturation above 90%, they're generally going to be fine. In fact, many of these people, if you can get their oxygen saturation up adequately, and they have stable lodging and people who can look after them, they can actually go back to their lodge and remain on oxygen there rather than getting admitted to the hospital. If they don't respond well to oxygen, you would consider starting nifedipine, maybe even a CPAP, continuous positive airway pressure. But in general, if someone's not responding appropriately to oxygen and maybe nifedipine, those people probably need to be worked down to a lower elevation if feasible. Okay. Now the other question that comes up is, high altitude pulmonary edema sometimes occurs alone, but sometimes you're going to see high altitude pulmonary edema in conjunction with high altitude cerebral edema. So people have both of these issues together. And so when you run into the problem is people with high altitude pulmonary edema, when they're really hypoxemic, they develop hypoxic encephalopathy. Simply low oxygen levels alone makes people really confused. And so the issue is, how do I tease out whether my patient with HAPE has hypoxic encephalopathy as a source of their confusion, or they have high altitude cerebral edema in addition to their high altitude pulmonary edema? What could you do as a quick little test to tease that out? You could try that and walk, and if you saw ataxia, that might make you suspicious. The challenge is when people have an oxygen saturation of 50% acutely, they may also just kind of be staggering around. What else could you try? Yeah, so how would that help? Perfect rationale. So if you have supplemental oxygen available, if you put them on oxygen and you raise their oxygen saturation to 90%, and all of a sudden their mental status improves and they perk up, they were just suffering from hypoxic encephalopathy. But if you put them on supplemental oxygen and raise their oxygen saturation to 90% and they're still confused, that's probably cerebral edema. Because cerebral edema, although it improves with oxygen, is not going to improve within just a couple of seconds of seeing your oxygen saturation go up. So, if available, the response to supplemental oxygen will help you tease that out. And why is this an important question? Well, I told you how to treat high-altitude pulmonary edema. And I mentioned that we don't use all the medications in your toolkit. But if your patient has HAPE and HACE at the same time, that's a person you want to also give dexamethasone in addition to nifedipine. Nifedipine for the HAPE, dexamethasone for the cerebral edema. Okay? All right. So our last case, you have someone who's trekking and has trouble seeing at one of their eyes. So the way they tell the story is they're trekking in Peru, and after they went over a high pass about 17,000 feet in elevation, this person noticed a problem with vision in one eye. She wears extended wear contact lenses and has had them in over the course of the trek. She has wraparound sunglasses that she's been using appropriately. When you examine her, she doesn't have any pain, the eye doesn't look red, so the sclera are clear. And then you ask her, describe your vision problem in more detail. And she says, well, when I close one of my eyes, this is what I see out the other one. So the question is, what are you going to do? Are you going to have her descend to lower elevation? Are you going to have her take out the contact lenses? Are you going to start on some ciprofloxacin eye drops? Are you going to start her on some oral dexamethasone? Or say, we're going to need to stay put for a couple of days right here. We're going to keep you in the tent and keep you out of the sun. Talk it over. See what you think. Descend to lower elevation. How many of you want to take out her contact lenses? About ciprofloxacin eye drops. Start some oral dexamethasone. And how about stay out of the sun for 2 days? This person needs to go down to a lower elevation. She actually has what's referred to as a high altitude retinal hemorrhage. So when we think about medical problems that occur at high altitude, we always think about AMS, HACE, and HAPE. But there are other things that can occur. Things not at all related to the altitude, but there are actually some other things related to the altitude itself that can get people in trouble. And one of them is this entity. It's very common when people travel above 16,000 feet in elevation. But the majority of people who develop high altitude retinal hemorrhage actually have no idea they have it. Because most people are asymptomatic because the hemorrhages are small or located in kind of the non-critical areas of the eye. And it's only when you do detailed studies looking at the retina of people traveling at high altitude you realize the incidence is pretty high. The people who become symptomatic are those who have large hemorrhages or ones that are well placed in the macula of their retina. And what they will have is painless vision loss in that eye. And on exam, The eye looks fine. The sclera is white. There's no irritation. There's no discharge from the eye at all. And in general, these people should go back down to lower elevation. They need to see an ophthalmologist and probably can go up to high altitude again in the future once this problem resolves. Okay? There are other eye problems that can develop at high altitude. When you travel at higher elevations, way more exposure to ultraviolet light, particularly when you're traveling on snow-covered terrain and there's a lot of reflected light. So you need to protect your eyes with good glasses and wrap-around structure or side shields. Otherwise, you can develop snow blindness. People who use extended-wear contact lenses, the oxygen supply to the cornea comes from diffusion from the environment rather than a vascular supply. When you wear contact lenses for too long, you diminish that oxygen supply and run the risk of corneal ulcerations that will develop. Those eyes also look very red, angry, and irritated, unlike the patient in this case. And then finally, people may ask me questions, hey, I had refractive surgery several years ago, can I go up to high elevation? Because they may have remembered John Krakauer's book about the disaster that happened on Mount Everest back in the 1990s of the Dallas pathologist who had radial keratotomy. And then all of a sudden got up above 26,000 feet on the mountain and could not see because of complications related to an interaction between the hypoxia and his eye surgery. So, basic patients and radial keratotomy patients may have some difficulty. Procedure known as photoreactive keratotomy is probably thought to be okay. So other issues do develop in other organ systems at high altitude. So to summarize in the last minute here, remember when people travel at high altitude, they're going to experience physiologic changes in response to the hypoxemia, and they're going to feel different. Be able to recognize those normal ways they're going to feel different and distinguish those from acute altitude illness. Descent is the single best way to treat any form of acute altitude illness, but it's generally only necessary for cases of high altitude cerebral edema or high altitude pulmonary edema or patients with AMS that don't resolve with appropriate therapy. If you're the medical person traveling at high altitude, carry along a pulse oximeter because it's super helpful in the evaluation of people who are having respiratory complaints. And then finally, we worry about AMS, haste, and hate, but other things happen to people when they're traveling at high altitude, like eye problems, like these crazy focal neurologic deficits. And you have to have a differential for the things that you're seeing in order to treat people appropriately. So with that, I'm done. I'm happy to take any questions if we have time. If not, I'll stick around and give you